Well, talking about VV ECMO, which supports the respiratory system rather than the hemodynamics, although there is some support, hemodynamic support, especially from correcting the acidosis and reducing the intrathoracic pressures due to high ventilatory settings. The main limitations or the main pitfalls of weaning VV ECMO patients arise from the basic pathology and the duration of mechanical ventilation that they were on prior to ECMO initiation. Usually we start talking about or we start planning our weaning and decannulation immediately after cannulation. After we stabilize the patient, we achieve the fluid balance that we wanted to achieve, we can start the weaning process while trying to optimize the respiratory function and the lung dynamics and the lung compliance mainly. And the minute we see that there are improvement in the chest x-ray and in the tidal volume regarding the ventilator, and we see that there's a rise in O2 sets, we can start the weaning process, meaning we have the preliminary conditions to may approach a successful weaning and eventually decannulation. There are several tests or assessments that we may do to have the whole picture about the respiratory condition of the child or the neonate. Usually we do oxygenation challenge. We try to wean the FiO2 in the membrane lung after we commence lung protective parameters in the ventilator. If we succeed to properly oxygenate the blood, we may approach to CO2 challenge test, where we turn off the sweep gas flow until we completely seize it or even disconnect the sweep gas flow from the oxygenator. And if the patient is stable, usually we maintain him with the ECMO flow, but without sweep gas flow for 12 hours or overnight. And if he's stable, with the lung protective settings, with the normal or near normal, let's say acceptable ventilation and oxygenation, we may proceed to decannulate him.